Hello, my name is Carla, and this is my concept map presentation. This is a 52-year-old female, full cold with allergies to lisinopril. She has a past medical history of COPD, acute bronchitis, congestive heart failure, tricuspid regurgitation. She has a 43 pack year history. She has pulmonary hypertension, obstructive sleep apnea, diabetes mellitus type 2, and hyperlipidemia. Her primary medical diagnosis is acute on chronic respiratory failure with hypoxia and hypercapnia. Patient considerations. So she is nicotine dependent. She stated that she had abstained from smoking. She did not say how long, but she recently began smoking again. Her mother had passed away 1 week ago in the ICU. Her husband had passed away 1 year ago, and she is homeless. She does not have a safe place to be discharged to. She is at risk for food insecurity, for medication access, and for access to transportation to her primary care consults. She does not have family support, and there is suspected substance abuse on her adult children and herself as well. She was having limited hospital visits during her stay. Pathophysiology. So it is important that we understand what gas exchange is. So this is a process that occurs at the alveolar membrane from the alveoli to capillary blood through diffusion. And this is where oxygen and carbon dioxide is exchanged. In acute respiratory failure, the lungs are not able to oxygenate or ventilate adequately, and it leads to oxygenation failure, which leads to hypoxia, and it causes ventilation perfusion mismatch. So, this patient already has COPD, and it was exacerbated by a viral infection called rhinovirus enterovirus, and this led to the development of acute bronchitis and resulted in acute respiratory failure on her existing chronic respiratory failure. The ABGs may reflect hypoxia and hypercapnia, indicating that gas exchange is impaired. This can affect the brain because hypoxia can cause decreased level of consciousness, and the cells are also deprived of oxygen, so it can lead to ischemia. In the heart, decreased oxygen supply can cause tachycardia and tissue ischemia. The lung vessels can constrict, making it harder for the right side of the heart to pump blood, and it can cause right sided heart failure. The kidneys. During respiratory acidosis, the kidneys try to compensate gas exchange by retaining bicarbonate ions, and in acute hypoxia, renal perfusion can be compromised. So, this can cause impaired kidney function and also um, electrolyte imbalances. Decreased oxygen supply to the muscles can cause weakness and fatigue, and this mainly affects the diaphragm, the intercostal, and the abdominal muscles. In the integumentary system, low oxygen levels can decrease tissue perfusion, and this can make the skin appear pale or cyanotic, and the extremities can feel cool. This also puts the patient at increased risk for skin breakdown. So, her cues. The vital signs: temperature was 97.8, blood pressure was 130 over 62, heart rate 76, respiratory rate 26, oxygen saturation 92%, 4 liters nasal cannula. On admission, her oxygen saturation was 57% on room air, and her temperature was 100.7. Her physical assessment. So she had ongoing expiratory wheezes, shortness of breath on exertion, accessory muscle use, abdominal, on 4 liters nasal cannula, but her baseline is 2 to 3 liters, 15 liters BiPAP at night, and frequent productive cough with consistent clear sputum, chronic fatigue, cool extremities, and ongoing droplet and contact precautions. So her white blood cell count is 3.95. Her absolute NRBCs is less than 0.01. Neutrophils 3.23. On admission, her carbon dioxide was 48, and on my clinical day, it was 40. Um, and she was tested positive for rhinovirus and enterovirus. The ABG's pH was 7.27, PaCO2 38, HCO3 35.4, and PaO2 60. She had imagery diagnostics, but the results are unavailable. So, the analysis of cues. Her respiratory rate is increased because she is trying to get rid of the excessive carbon dioxide, and her oxygen saturation of 92% on 4 liters nasal cannula indicates that her oxygen saturations are not stable compared to her 2 to 3 liter baseline. Upon admission, her oxygen saturation was 57% on room air, and her elevated temperature is likely due to the positive infection that she had. Ongoing expiratory wheezes um, can happen due to narrowed airways, likely due to constriction, inflammation, or increased mucus production. And the shortness of breath on exertion occurs because the oxygen demand during activity is increased and the body is not able to compensate. So, this can lead to worsening hypoxia. Accessory muscle use indicates increased work of breathing and diaphragmatic fatigue. On 4 liters, nasal cannula indicates increased oxygen demand due to acute respiratory failure because her baseline is 2 to 3 liters. And 50 liters BiPAP at night indicates that she needs support to maintain airway patency during sleep due to obstructive sleep apnea. Frequent productive cough is the body's mechanism to clear secretions from the airway. The patient had green to yellow sputum, but it changed to a clear color, indicating that the infection is subsiding. Chronic fatigue and cold extremities are likely caused by chronic hypoxia, as the peripheral tissues are not receiving enough oxygen to perfuse. Ongoing contact and droplet precautions indicate that the patient has a contagious respiratory infection, which is rhinovirus and enterovirus, and she requires isolation to prevent transmission through respiratory droplets and surface contact. So her white blood cell count was 3.95 on the clinical day, but on admission, she did have leukocytosis, which is an indicator of infection and chronic inflammation, and her carbon dioxide is significantly elevated. And it can be an indicator of respiratory acidosis, which means that she is retaining carbon dioxide and is causing impaired gas exchange. And her ABGs indicate respiratory acidosis partially compensated. So, my nursing diagnosis was impaired gas exchange and ineffective airway clearance. So, the reason why impaired gas exchange is my priority nursing diagnosis is because a patient developed acute on chronic respiratory failure, which is life threatening as it affects the tissue oxygenation. She presented to the ED with an SpO2 of 57% on room air, and this acute drop in oxygen saturation can put the patient's life in danger and can cause multi organ failure. And ineffective airway clearance is my second nursing diagnosis because oxygenation has to be stabilized first, and then we can take interventions to clear the airway from secretions. And this can be during the hospital stay. She was tested positive for rhinovirus and enterovirus, which caused the collection of sputum in her lungs. So, my goals for impaired gas exchange were that by the end of my 8-hour shift, the patient would maintain oxygen saturation levels above 92% on 4 liters of oxygen therapy. She would perform deep breathing exercises at least 10 times per hour to promote ventilation and would decrease respiration rate from 26 to 18 respirations per minute. She would perform appropriate return demonstration of the incentive spirometer and would utilize it at least 10 times per hour. She would verbalize three benefits of smoking cessation and would verbalize how smoking worsens her chronic respiratory failure. And she would verbalize at least three safety precautions of oxygen therapy and verbalize why these are important. My goals for an effective airway clearance were that by the end of my 8-hour shift, the patient would perform deep breathing and coughing to expel accumulated sputum at least 3 times per hour. She would perform appropriate return demonstration of the incentive spirometer and would utilize it at least 10 times per hour. She would verbalize at least two signs of worsening infection and what actions to take, and she would verbalize at least three ways to prevent the spread of viral infections to protect themselves. So, nursing interventions for impaired gas exchange include auscultating anterior and posterior lung sounds every 4 hours. This was effective. The patient's expiratory wheezes were diminishing as she was coughing out the sputum. Continuously monitor oxygen saturation levels. This was effective. She remained at 92% oxygen saturation at rest. Monitor respiratory rate patterns, including depth and use of accessory muscles. This was effective. She was able to perform deep breathing exercises, assess sputum color, odor, and consistency. This was effective. Her sputum remained clear throughout my shift. Teach the patient use of incentive spirometer. This was effective. She was able to perform incentive spirometer repetitions in between television commercials. Discuss with patient the importance of smoking cessation. This was effective. The patient has a very strong knowledge about what exacerbates her COPD. Assess ABGs to monitor patient's gas exchange was effective. She had ABGs done upon admission, and the results indicated respiratory acidosis. Pharmacological interventions for impaired gas exchange include administering methylprednisolone 62.5 milligrams per milliliter every 8 hours. This was effective because this medication helps to reduce airway inflammation, and administering a nicotine patch 14 milligrams every 24 hours was also effective. One patch was administered during my shift, and this can help with smoking cessation. Other interventions was 4 liters on nasal cannula. This was effective. It maintained the patient's oxygen saturation above 92% at rest. 15 liters of BiPAP at night was effective. She uses the BiPAP at night to manage her obstructive sleep apnea, and a chest x ray was also effective. She had one done upon admission, and this can help us visualize what's going on in the lungs, for example, atelectasis, pneumonia, or a pulmonary emboli. And case management was also effective. It coordinated discharge planning, oxygen needs after discharge, and follow up appointments with their primary care. Nursing interventions for an effective airway clearance include auscultating anterior and posterior lung sounds every 4 hours. This was effective. The patient's expiratory wheezes were diminishing as the patient was coughing and expelling out the accumulated sputum. Continuously monitor oxygen saturation levels was also effective. The patient was connected to continuous pulse oximetry and remained at 92% at rest. Have the patient positioned in high Fowler's position. This was effective. She was sitting up in the recliner during my whole shift, and this would help with her lung expansion when she was performing her deep breathing exercises. Assess sputum color, odor, and consistency. This was effective. The patient's sputum remained clear throughout my shift. Teach the patient the use of incentive spirometry. This was effective. The patient was able to use the incentive spirometer in between commercials. Monitor white blood cell count. This was effective. My patient's white blood cell count was low during my clinical day. However, she did have leukocytosis upon admission. Pharmacological interventions for an effective airway clearance included administering methylprednisolone 62.5 milligrams per milliliter every 8 hours. This was effective as it was going to help reduce the airway inflammation caused by the rhinovirus and enterovirus, and administering viromycin 100 milligrams per Oz was also effective. This antibiotic was also going to help with the rhinovirus enterovirus infection that the patient had. Other interventions included 4 liters oxygen through nasal cannula. This was effective. It helped maintain the oxygen saturation levels at 92%. 15 liters of BiPAP was also effective. The patient uses the BiPAP at night to manage her obstructive sleep apnea, and a chest X-ray was also effective when was done upon admission, and it can help us visualize what's going on in the lungs. So now for the evaluation of goals for impaired gas exchange, the patient did maintain oxygen levels above 92% with 4 liters of oxygen therapy, so that goal was met. So second goal was not met. She was able to perform deep breathing exercises during my rounds. However, when I took scheduled vital signs, her respiration rate did not decrease from 26 to 18 or 20. It remained very high. The third goal was met. She was able to perform appropriate return demonstration of the incentives barometer, and she did use it at least 10 times per hour. She said she utilized it during television commercials. And the fourth goal was also met. She was able to verbalize that smoking can put her at an increased risk of throat and lung cancer, and that smoking can exacerbate her COPD. The fifth goal was not met. She just said that smoking while on her oxygen tank is dangerous. So I educated her on not having her oxygen tank near hair dryers or open flames like candles, and to have a fire extinguisher in the room is recommended. Evaluation of goals for ineffective airway clearance. So the first goal was met. The patient was able to perform deep breathing and coughing to expel accumulated sputum more than 3 times per hour. The second goal was also met. She was able to perform appropriate return demonstration of the incentives barometer, and she reported using it more than 10 times per hour. She said she used it during television commercials. The third goal was also met. She said that a change in the color of her sputum and an elevated temperature of more than 99.0 Fahrenheit could indicate that she was having an infection and that she would follow up with her provider. And the fourth goal was also met. She stated that avoiding crowded areas, washing her hands for more than 30 seconds, and wearing a face mask can protect her from getting an infection.